Hi, my name is Fred Rotnick. I'm a faculty physician at St. Louis University and the program director for our Addiction Medicine Fellowship. Today, I'd like us to take a look at alcohol use disorder with some special considerations during the COVID-19 pandemic. This slide describes some of my clinical work and academic work. Most importantly for this presentation, I'm medical director at Assisted Recovery Centers of America, where we do in-person care as well as telehealth, addiction medicine, and treatment of co-occurring disorders around the state of Missouri. COVID-19 has changed pretty much everything in our lives right now. So today we're going to apply a COVID-19 lens to the following objectives that I originally had put together for this presentation. We'll talk a little bit about epidemiology and impact. We'll talk about screening tools. We'll talk about identifying patients at higher risk and at lower risk for a complicated alcohol withdrawal. And then also we'll talk about tools for harm reduction and medications and other treatments for the chronic treatment of alcohol use disorder. So why the renewed interest in alcohol use disorder? The mandate to isolate that we should be following right now is complicating people's lives in ways that we didn't expect. If we consider substance use disorder and social isolation, those are not good partners and they can have dangerous consequences. If we add to social isolation unemployment, layoffs, furloughs, insecurity around housing, around food, unsafe relationships at home, domestic violence, intimate partner violence, all these things are thrown into the mix that can really escalate someone's use of controlled substances and psychoactive substances if people are looking for escape or relief from anxiety and from other unsafe situations that are developing from this increased social isolation and increased time with family and friends. Couple that with the changing supplies and access to supplies of opioids during this opioid epidemic, and we're seeing changes in behaviors among people who have been using. Cross-addiction is real. Cross-addiction being when someone transfers from use of one substance to another. And as a result, we're seeing liquor sales skyrocketing. We have not really paid attention to alcohol use disorders and tobacco use disorders in ways we should have in recent years. A lot of that has been due to the immediacy and death associated with opioid use disorders in recent years. The availability of synthetics and semi-synthetic opioids have turned risky use into possible death. However, far more people in the U.S. have died from alcohol use disorders and tobacco. Yet we've let our guard down, and now it's time to reconsider: how do we screen, how do we treat, how do we help people with an alcohol use disorder? First, we'll take a look at a few definitions that we've used around this topic. Very common slide is in front of you right now when we talk about what is a drink. And it gives us, again, a refresher on the idea of what's essentially an equivalent dose of alcohol. A blood alcohol level chart can be very useful, not only, of course, for what it's there for, to tell us about the correlation between alcohol use in terms of number of drinks and possible side effects of that. But it's also a useful teaching tool with patients to give them an idea of correlations on average of drinks to behaviors, to legal consequences, and to other problems that may result from excessive alcohol use. It's always good to have blood alcohol level charts readily available in exam rooms and in other places that patients can see. It's a great conversation starter. The DSM-5 brought changes in definitions and changes in how to evaluate the severity of a substance use disorder. Symptoms were simplified in many ways into behaviors or into activities, things that can be reported and quantified more simply, such as increasing the amount of substance one uses. Since we're focusing on alcohol, we'll talk more about alcohol here. Talking about persistent desires, unsuccessful attempts to quit, the ability to fulfill major roles at work, school, and home, interpersonal problems or social problems. They fit into these broad 6 buckets, but the 11 criteria allow a provider to talk about the severity of a substance use disorder, starting with 2 to 3 symptoms. It would be considered mild, going up to a severe substance use disorder with 6 or more criteria included. This is useful, simple language about behaviors, and it's language that can be included into the EHR to be used as a bit of a screening tool as well as a diagnostic tool. Many of us have seen this slide from 2017, where approximately 72,000 people died from drug-related overdose deaths. We know now that deaths due to opioids for most states has leveled out in 2019. We're still looking for data, but in 2018, by and large, these opioid-related deaths leveled out through most of the United States. Missouri and Delaware were the only 2 states that saw a significant increase in opioid deaths. If we see this slide, however, we also notice that deaths from cocaine and methamphetamine were increasing in 2017, and they still continue to increase, especially in the area where we're in St. Louis, where we're seeing that much of the supply of opioids is tainted with amphetamines. In this slide, we can see a comparison to the roughly 72,000 deaths from opioids on the previous slide. This number gives us deaths in 2016 from alcohol. About 88,000 people died from complications of alcohol use. Of course, most of these deaths are from chronic alcohol use, though some are from alcohol poisoning, particularly in young people. These numbers have continued to increase, though I do not have most recent data on this. What this tells us, though, as a nation, is that the top 3 causes of death in the U.S. are tobacco, complications from poor diet, and complications from alcohol use. As mentioned earlier, we haven't focused on these as much in recent years, but with changes that we're seeing right now, with changes in opioid supplies, that's why we're looking at this today. The National Survey on Drug Use and Health from 2016 reinforces the connection that we see among folks with a substance use disorder and folks with a serious mental illness. We know that these conditions do not occur in isolation, and my guess is that these numbers are relatively conservative because this survey is all self-report. These numbers also are indicated not to have changed significantly from 2015. A new survey has been published in recent years, and it does not show a large difference from these numbers. A reinforcement of the previous slide. This just shows the odds ratio of people having a serious mental illness and people having alcohol use disorder. Blue is any alcohol use disorder. Red is severe, again, based on the DSM criteria. Now that I've spoken a bit about the impact, let's talk a little bit about prevention. It's always important to look at what works with younger people so we can see how to prevent the problem before it becomes a problem. There are some evidence-based programs that have been very successful, including social resistance skill training, how to focus on competence and enhancement of those competencies with young adults and children in terms of finding things that adolescents do well, that add value and positivity to their life, and how to build around that. Normative education, or called denormalization, works with kids who are raised in high-risk environments in terms of parents actively using drugs or alcohol, and kids growing up with the message that heavy alcohol use or drug use is a normal activity. Identifying these kids and intervening to help them understand that these behaviors are not normal is what is at the core of this intervention. Other prevention methods that work very well fall under the bucket of environment. We see these regularly with media campaigns where we try to educate and motivate people away from using substances. Ways to reduce supply of substances, and that can be things like zoning laws and limiting the number of alcohol vendors in a given geographic area. Decreasing access to substances can be limiting supply, but it can also be monetary interventions in the form of taxes. We have been able to greatly decrease tobacco use in the United States by using environmental prevention techniques. In 1955, which was kind of the height of tobacco use in the United States, about 50% of people smoked tobacco on a regular basis. Now that number is down to about 18%. And those of us who are old enough to remember can see these changes where taxes went up quite a lot, where people started pulling vending machines for tobacco and cigarettes out of restaurants, limiting the age for tobacco use. All these things are considered environmental prevention, and they're techniques that work, and they're techniques that we can use in different ways today. Here are a few screening tools that are recommended by professional societies to be done on at least an annual basis. Audit C is one of the simplest ones. This is something we teach students at St. Louis U to use with standardized patients. Simple questions: how often do you have a drink containing alcohol? Second, how many drinks containing alcohol do you have on a typical day that you drink? And the third is, do you ever have 6 or more drinks on one occasion? Again, these are drinks that we define using those tools and that slide we went over earlier. This gives you an approach to talk to patients, to use an SBIRT screen if you use that in your clinic, which is screening, brief intervention, and referral to treatment. Another evidence-based tool to open the conversation when you're concerned that your patient might be using excessively or using in a risky manner. A second screening tool that's one of my favorites is a craft tool. It's geared towards adolescents because it's language that is used is language that is not accusatory. It's language that, again, focuses on behavior, and it's language that anyone can use in a screen, including a parent. The question I really like on this is what they call the car question. Have you ever ridden in a car driven by someone, including yourself, who was high or had been using alcohol or drugs? Again, remember, these are screening tools. These are not diagnostic tools. but they are a way to open a conversation on an otherwise difficult topic. This slide gives you a few more evidence-based screening tools that are useful. The key with these tools is pick one. If your system or your practice already has one of these integrated into the EHR, use it. Use it on an annual basis. Have someone on your team administer this. Some screening tools are meant to be done by the patient themselves or by the client themselves. Some are meant to be done in an interview style. Find what works. The person doing it can be a peer support specialist, a medical assistant, a nurse. It doesn't all have to be done by the prescribing provider. These screening tools are also really helpful to catch increasing or decreasing use of substances. But again, their greatest power, in my opinion, is as conversation starters. When someone is ready for treatment for alcohol use disorder, it's important to start off with a conversation around treatment goals. Sometimes total abstinence is a goal. Sometimes it's decrease of risky use or moderation of drinking in social environments. Find out what your patient's goal is, what he or she wants to do. Then that gives you an opportunity to talk about risks. What are risks of alcohol use, especially unsafe use or excessive use? That can be occupational challenges, safety issues around driving, physical health, and then also find out what is motivating your patient. What have they done before? Is this the first time they are seeking treatment? Have they tried treatment in the past? Get a good psychosocial history about substance use disorders in the family, and see what their resources are as well for success. When a patient's seeking treatment, always ask early on if they are seeking treatment independently or if they are engaged in a treatment court or diversion court, particularly around alcohol, because many of these courts have mandated reporting. They have expectations or communications required from the treating provider. So just make sure you know up front what your role is and what your reporting role is working with a patient. Now let's take a look at the management and treatment of alcohol use withdrawal or detox. There's generally 4 stages. Not everybody goes through every stage. Not everybody has the same severity at each stage. Your progression through these stages would depend on how much one drinks, what one drinks, how long one's been drinking, age, and co-occurring medical problems and co-occurring mental health problems. These 4 stages have been adapted from Dynamed Plus. These 4 stages are of increasing severity, resulting in DTs at stage 4, which can cause death. Many of us in the healthcare field have been taught that acute detox or acute withdrawal should be managed in the hospital setting, and that would be great if everyone had access to that. But many people do not, especially now during COVID. People may not have insurance, they might not have access, they may not be able to take time off work for an inpatient stay. They may not be ready to commit to that. Not everybody needs an inpatient detox. So let's take a look at a few validated tools that can be used to help determine whether or not we can work with a patient to detox at home. And in all these situations, you want to document your medical decision making. You want to offer the best opinion you can and document the plan that you've come up with your patient, whether or not detox is a good choice right now, the venue, and safety plans related to the process. The PAUSE scale was published in 2015. This is a prediction of alcohol withdrawal severity scale, a very useful tool to give you an idea of how complicated you can expect a withdrawal to be for a patient. They ask about everything from last drink to have you had complicated withdrawals in the past, and they break that down by blackouts, withdrawal seizures, DTs, etc. The scoring is at the bottom of this page, and again, it gives you an idea on how to plan with your patient. Every provider has to figure out the comfort level to try to do a home detox with someone. And we'll put some resources and other supports in place in a couple slides. The CIWA, or Clinical Institute Withdrawal Assessment for Alcohol, revised, the CIWA-AR, is the evidence-based validated tool that is used to follow a patient in the detox process. Take a look at the scale. There's a maximum possible score of 67. These items are combinations of questions and observations. Usually this is administered by the nurse or the person caring for someone in the hospital, but it can also be used with someone at home. It can also be used as a self-assessment. A useful cut on this scale is 10. Someone who scores lower than a 10 does not usually require additional medication, meaning benzodiazepines, for the withdrawal process. Hospital-based detoxes have been routinized fairly well. This is an adaptation of Dynamed Plus's recommendations. There are three basic categories of treatment. Perhaps the most important is hydration, or IV fluids. The second is administering thiamine, folic acid, and multivitamin. And then third is use of benzodiazepines. Benzodiazepines treat agitation and minimize progression through the 4 stages of alcohol withdrawal. There's a few different ways to look at dosing patterns. However, most institutions have a protocol for administration of benzos during detox that fits well with their overall staffing pattern. Home-based detoxes. Let's take a look at the acute situation or the acute setting, the first few days of detox. Again, consider home detox if someone rates low on the PAUSE scale for risk of complications during withdrawal. Again, these recommendations are pulled from Dynamed Plus. Most of the goal of a home induction is, again, controlling the symptoms, controlling metabolic abnormalities, same basic principles of intervention with hydration, with thiamine and multivitamins, and with benzos. Benzos can be used safely at home, which is one of the reasons why it's very important that if somebody tries detoxing at home, they have someone at home with them. This person can look for red flags, they can look for delirium, they can be in contact with the patient's provider. They can also be the person in charge of administration of benzos for a safe detox process. This is ARCA's basic detox protocol, which we can adapt as needed for individual patients. These are for people at low to medium risk on the pause scale. And if someone is unable to go to the hospital to detox, this is another option. Note that hydration is not included on here, but it's a very important part of the process. We encourage patients to pre-hydrate prior to starting detox, and then during the detox period to drink non-caffeinated beverages consistently. If someone's watching TV, a great way to do that is to take a couple sips of water during every commercial break. A very important part of detox from any substance is the need to support the patient to be as comfortable as possible throughout detox. These are 3 typical comfort meds we will use at ARCA for alcohol detox. Trazodone is a sleep aid, compazine to help with nausea, and clonidine to help with rebound hypertension, to help with some of the jitteriness and restlessness that a patient may have. There's variations for these comfort meds, and also some of these comfort meds may not be appropriate for all patients. But keep in mind, the more comfortable a patient is during detox time, the more likely they're going to be successful with the detox. Labs and other monitoring needs. Here's our basic initial labs and follow-up labs. Notice that in this slide set, I have included ideal in front of all these labs. Ideally, yes, we want to see a patient face-to-face. Ideally, we'd want to make sure that their liver function and kidney function and their blood count are all fine, and we wanted to have a UDS. We want to make sure women aren't pregnant. But in the age of COVID, we don't always have those options. We do things at ARCA that include trying to get medical records within the year to find these lab values. We may encourage our female patients to go to their local pharmacy to pick up a pregnancy test and perform it. We might order a UDS and some labs for the patient to go to a local Quest or LabCorp or other commercial testing site to get those labs done at their first available opportunity. The meds that we use in this detox process are meds where the benefit of starting the meds, even without labs, are greater than the risks associated with not engaging in detox. At ARCA, we almost exclusively use naltrexone as our chronic medication for management of alcohol use disorder. There are 2 other agents out on the market, acamprosate, which does do better than placebo, but acamprosate requires 3 times a day dosing, which makes adherence very difficult. Disulfiram's been around for decades. It's more of an aversive approach to alcohol use. Disulfiram creates a reaction once you have it on board that makes a person incredibly uncomfortable if they drink. So it's not a very attractive offer to most people. It's usually used as the last option of the 3. There's also non-pharmaceutical treatments, of course, different types of therapy and psychotherapy, and we'll talk about those as well in future slides. One evidence-based method that is very useful for people seeking either complete abstinence or reduction of alcohol use is the Sinclair method. The advantage of the Sinclair method is people can start taking oral naltrexone and they do not have to be alcohol-free while they use it. The Sinclair method addresses the chemistry that occurs as a mu receptor. At the mu receptor, the opioid receptor, naltrexone is an antagonist. It occupies the receptor site at a higher affinity than alcohol does. In other words, if you have naltrexone on board and you drink alcohol, you do not get any buzz, any reward by a dopamine push. You do not get any association of pleasure or euphoria from drinking because the naltrexone occupies the receptor and sticks to it stronger than alcohol will. So alcohol is simply metabolized and excreted. When you have naltrexone on board, think of it as a vaccine or a protection against alcohol use. An individual may still drink alcohol, but they're not going to get the euphoria or pleasurable sensation associated with prior use. A real advantage of this is that the Sinclair method can be used if somebody's still actively drinking, and it will protect them against the euphoria of use, and it disconnects the drinking with the pleasurable response. In time, with or without therapy, by decoupling the drinking with the reinforcement or response of dopamine, people will gradually cut down their alcohol use. Resources for the Sinclair method can be found at these sites, including a movie which was produced in 2014, which can be rented or streamed online. The next few slides from the American Psychiatric Association details naltrexone, acamprosate, and disulfiram, and talk about risks and benefits of each measure. This slide addresses medication selection and treatment. Sometimes a patient comes in with a particular preference for a specific medication. Maybe they found success with that before, maybe they'd relapsed and now they'd like to try again. Or perhaps they had a previous use of a medication and did not like the side effects. They've relapsed, they've come back in, they want to try something different. Our second major bullet point on this slide is important because not everybody has the same problems with alcohol. Some people are daily drinkers and they drink too much. Maybe they want to quit completely. Other folks have problems with risky use, perhaps when they travel or around holiday times, and maybe for them, they want to use naltrexone for harm reduction, similar to what we talked about with the Sinclair method. They might be in a situation where the pressure is overwhelming for them to drink, but maybe they can protect themselves by using naltrexone. And then finally, you want to compare what are other co-occurring issues going on with the patient. Does one medication need to be avoided because of renal or hepatic considerations? Might one of these medications have a side effect with another class of medications? Most of these medications are very safe, but these are things to think about in terms of long-term use. This slide addresses therapies that are effective in this work. Almost always, having a therapeutic intervention is going to add benefit to the medication someone's taking, because the therapies can help an individual look at the underlying causes of addiction, what's going on in that individual's life that help them think that using a substance in a risky way would be a good choice for them. Motivational enhancement therapy, cognitive behavioral therapy, and medical management are all methods that have been around for decades and have shown to work well. There's also community-based peer support programs, some faith-based, some not faith-based. Alcoholics Anonymous has been around for decades. Also, Smart Recovery is a non-theistic 12-step program which includes more intentionally more cognitive behavioral therapy. Many groups in the area are available for this, and many groups in the St. Louis region can be found through the NCADA site by zip code and by interest. It's important to remember for everyone on the treatment team, as well as the patient or client and that patient's family, that alcohol use disorder is a chronic condition. These bullet points are abstracted from the American Society of Addiction Medicine's short definition of AUD as a chronic condition and its definition of addiction. It's important, as with all chronic diseases, that a person has good days and has bad days. There are times when somebody's going to be challenged by external triggers. There's times where somebody may relapse. This is not an opportunity to call somebody weak or lazy. It is a natural consequence of the chronic disease status of any primary condition. Here are some very useful resources, some oriented to the public, some to providers, some to academics. Finally, this slide contains my contact information, my email address at St. Louis University. I can also be contacted through ARCA. I like to conclude many of my slide sets with patron saints. On the left, we have St. Monica of Africa. On the right, we have St. Augustine of Hippo. St. Augustine had a very rich and colorful life before he ended up entering the priesthood as a young man. Part of that colorful life was excessive alcohol use and also fathering a child out of wedlock. My favorite quote of him from his early life is, "Dear Lord, make me pure and holy, but not yet." After he entered the priesthood, many of the responsibilities that he created, including his son, were looked after by his mother, St. Monica, who's pictured here. And St. Monica is, no kidding, the patron saint of long-suffering mothers. So I think this duo is a great visual way to close up our time today. I applaud your efforts in doing this work. We need to do a better job in the United States of addressing both alcohol use disorder and tobacco use disorder. We talked about the whys earlier on in our presentation, but particularly in this age of COVID, we need to have discussions about alcohol use with our patients. We're going to be seeing a lot of people transferring their substance use disorder from opioids, from methamphetamines, from other items that are available now, but in much restricted quantities and at much higher price. A lot of people are going to be transferring their addictions over to alcohol and tobacco as legal options. And though we should see that as an opportunity to offer treatment and to help people create the lives they want and deserve. In our profession, we can have those difficult conversations. We can support people in recovering towards flourishing. And I hope that this presentation today was an opportunity to do just that. Thank you very much.